what is the role of transplant for myeloma, or why do I choose to call it the Tom Brady of myeloma? I call it a Tom Brady of myeloma because if you want to win the game and carry the trophy home, you want to bring him early on in the game. Don't expect for Tom Brady to come in the last 5 minutes and carry the trophy home. This is based on two large randomized clinical trials that were done in US as well as in Europe that looked at the question of early versus late transplant for a new myeloma patient. Early transplant means that we are doing it after 4 cycles of frontline chemotherapy, and late transplant means doing it upon relapse 4 or 5 years later. Both trials showed us the same result. If you do an early transplant, which is within 4 cycles of chemo or 6 months of your diagnosis, you tend to get into a deeper and a longer remission, which can actually last 7 years in modern times and age. Having said that, it does not necessarily make you live longer compared to folks who don't do transplant early on. With a caveat that patients who actually have a high-risk myeloma, there is a significant benefit of transplant when compared to not doing the transplant. And that's a group of patients we strongly recommend transplant. I put all of my thoughts regarding the role of transplant for a new myeloma patient in this article. It was published where I go through the reasons why we should do transplant early. Just to summarize this, I believe most myeloma patients, especially when they're in their late 60s, early 70s, they only grow older with time. As they grow old, they acquire more comorbidities, more medical conditions, they lose their medical physical fitness, they may not have a caregiver, may not be able to collect stem cells. So I like to get the transplant done early so that we can avoid all of these problems later on in life in case we need transplant. The only time I may choose to collect stem cells after about 4 to 6 months of chemotherapy and keep it reserved for a rainy day is when I have a young patient, a fit patient with a good kind of myeloma who has a very strong reason, social reason, family reason to delay transplant. But again, I recommend collecting stem cells after 4 to 6 cycles. Moving on to the maintenance chemotherapy, as of now, the ritual in US is that we start maintenance with chemo pills with or without injections of chemotherapy and continue them till the rest of the patient life, as long as the myeloma is responding and a patient is tolerating. Having said that, there are multiple trials going on at different sites in the US, including MSK, that are looking at limited duration maintenance. What we have learned from them is that if you do 2 years of maintenance chemotherapy and you run a bone marrow special test that shows deep level of remission, you can actually reliably stop maintenance chemotherapy. There's a big trial that I participated in where I was in South Carolina that's looking at nearly 1,500 patients where they're stopping their maintenance after 2 years and see if they relapse or not. I think we'll know from this trial result in the next 3 to 5 years where we will know what to do with the duration of maintenance chemotherapy. But in my practice, if I have a patient who has had 2 years of maintenance, is in a deep level of remission based on bone marrow biopsy test, and is interested in stopping maintenance, I am open to that idea and discussion. Let's talk about some of the basics of myeloma regarding some of the complications, vaccines, and infections. Myeloma bone disease is common, usually affects your spine and your pelvis, can be debilitating. Radiation therapy is a very effective remedy for it. I also look into kyphoplasty, which is a procedure where they can actually inject some cement and numbing medicine into your bone, give it more structure, give it more strength. And then I also have my patient go on bone modifying therapy in the form of Zometa and Xgeva on a monthly basis. We give them some calcium, vitamin D. We make sure they have dental hygiene with it. Infections are very common. They happen because the immune system is compromised with myeloma and myeloma therapy. Every patient should be on acyclovir or valacyclovir to prevent shingles. And I strongly recommend discuss with your physician when you can get Shingrix vaccine. I typically tend to avoid that in patients who are on chemotherapy. I strongly recommend influenza vaccine, COVID vaccine, as well as RSV for myeloma patients. And then some chemotherapy-related side effects, which are very common. I hear from it my patients all the time. I just want to quickly walk you through those as well. Cramps that you notice oftentimes in your hand and your feet into nighttime, they're related to Revlimid and Pomalyst like chemotherapy. Tonic water, mustard mix in water, pickle juice are some of the remedies that have worked very well for patients. Neuropathy is a very common side effect. If you've been getting bortezomib-based chemotherapy twice weekly, it happens in nearly 60% of the folks. I recommend my patient taking some medication to help relieve the pain, walking long distances, because every time you are stationary, you are immobile, that pain gets flared up. Cancer-related fatigue is a very common phenomenon. All patients who have some sort of malignancy are getting chemotherapy for it will have some degree of fatigue and weakness. The answer lies, and I know it sounds counterintuitive, in physical activity. I'm asking my patients to do exercise when they're fatigued, but trust me, it works. Going to a gym, working with the therapist in the gym, participating in activities like swimming is very helpful. And finally, chemotherapy will affect your taste buds, so your taste may become metallic and altered. Again, looking into food items that you've never tried before, sweet, cold, beverages, fresh fruit, salads is very helpful. Try what you have not liked before, and you may see notice a difference.